Innovation, imagination, wonder. These are just some of the words used to describe Dr. Harvey Passes. Dr. Passes explores interesting people and ideas that will stimulate you. He questions the people who develop, create, and employ novel concepts in business and everyday lives. He especially loves to speak with successful people. How did they do it? How can you do it too? So let's join Dr. Harvey Passes in his quest of wonder and curiosity as we watch Dr. Harvey Passes Presents.
I keep telling you over and over and over again that Long Island has some of the finest resources in the world, truly world-class resources. Beaches are great, food's great, the place, everything's great, but we have some of the finest physicians and surgeons in the world. And you can see the way I'm dressed. I'm back in my scrubs. That's right, because we are going back to the health field today. And you're going to learn and see an area that for many people is a big mystery. And you're going to meet with truly one of America's experts on this field. Would you like the way I open that up? Isn't that great? I got a smile out of you. You're going to meet a wonderful, wonderful guest today who, well, let's get right down to it. You're going to meet Dr. John Procaccino. Dr. John Procaccino is, he is the director of colon and rectal surgery and diseases at North Shore. Not LIJ, just North Shore.
North Shore LIJ system.
North Shore LIJ system. And this man is absolutely brilliant, very well respected. You know, I promised him that, that I was going to mention a little bit to establish his credentials. Believe me, he's got credentials. But if I go through all this, the show is over. It's just huge. I mean, it goes back, my God, from medical school to his internship at some of the finest places around, and he did residencies at North Shore. Then he was a chief resident at the Cleveland Clinic, and then from there he's been, oh God, it just goes on and on. I'm not going to go through all of this because, I mean, you're an unbelievable guy. He's written articles all over the place involved in his field, and he's incredibly well respected. Member of the American College of Surgeons, American Society of Colorectal Surgeons, New York Society, it goes on and on and on, Long Island Gastroenterologic Society. This guy knows what he's talking about. So let's begin right now, and I'd like you to meet Dr. John Procaccino. Hi, John.
Harvey, thanks very much for having me. I appreciate it.
It's great. You are a busy man. I think I'm busy. You're a busy man. And to grab you from your practice in the hospital is a big deal. And I thank you for coming down here. I told my viewers that we're going to be talking about diseases of the colon and the rectum, the whole tract. And it's a disease that the average person can't look inside. Whoop, something's going on there. Can't see it. So we don't know what's going on. I want you today to explain, demystify, to educate the viewers so that they understand what it's all about and how certain illnesses are possibly prevented or other illnesses can be treated if we have detection early. Am I right?
Correct.
Okay. So first, let's begin so that people know where we're starting. What is the GI tract? Don't say government issue.
Well, you have to visualize the GI tract or the gastrointestinal tract as a tubular specialized organ system. It starts at the mouth and it has different organs which perform different functions.
Starts with me.
Correct. We actually have a simplified little placard here.
Right.
The GI tract begins at the mouth, and as you are well aware, the teeth start the digestive process by breaking the solid foodstuffs down.
Right.
That food is then swallowed and goes via a food tube from the base of the mouth or the pharynx, and it brings the food, which is chewed up, down into the abdomen. That tube is called the esophagus. In the abdomen is a hollow organ called the stomach, which has a low pH and a high acid content where chemical digestion begins. After that, the partially broken down foodstuffs move into the so-called small intestine, which is about the diameter of a garden hose. It's about 15 to 20 feet in length.
Isn't that amazing?
And in the small intestine is where the foodstuff absorption of nutrients occurs. Beyond that, we start to get into the realm of the organ systems that I deal with, called the colon, which is a tubular organ about 4 to 5 feet in length, about 2 inches in diameter. The lining of it looks like the pink glistening lining inside your mouth. And it is this lining that can give rise to various disease processes. The function of this organ is to reabsorb the liquid waste delivered to it from the small intestine, and as the waste traverses the various parts of the colon, the ascending, the transverse, the descending, and here the sigmoid, the stool is changed from liquid to solid. And its volume gets smaller. The last waste station, the last 6 inches of the intestinal tract, is a storage organ for that waste. That's what the rectum is. It just stores the solid waste made by the colon, and then that exits the body as that area attaches to the buttocks. There's a muscular, specialized muscle there called the sphincter, which is responsible for control. So in a very quick snippet, that's what the GI tract is.
Perfect. Okay, so, and the rectum, as you said, holds it and stores it until, boom, you're ready to evacuate it.
Correct.
Okay, now, what are some of the diseases that are going to affect the colon?
Perhaps one of the most common is colonic polyps, and what the colonic polyps can lead to is colon and rectal cancer. Colorectal cancer, which I'm sure you and our guests have heard about, is actually the second most common cause of cancer death in the United States. Believe it or not, more women in New York State last year died of colon cancer than died of breast cancer.
And nobody would believe you.
Correct.
Because breast cancer gets all the PR.
Correct. I mean, this is not a topic you really want to discuss over the kitchen table.
Well, we should be doing this somewhere. I'm doing it on TV right now. It fits it perfectly. Okay, so colon cancer is a biggie. There's no question. What are polyps? And I think we'll get a chance to see one.
Absolutely. Polyps are growths or excrescences that develop from the lining of the colon. They can either have a stalk and a head looking like a
piece of broccoli coming up,
right, or a mushroom, or they can sit flat on the colonic wall. They have different names. The ones with the stalk are called pedunculated, like a pedicle, like a clapper in a bell, and the flat ones are called sessile. They look like a coin sitting flat on the bowel. We actually have an example of that.
So, okay, let's see if we can run the example. We have, ladies and gentlemen, you're about to see your first colonic polyp, and you'll see what it looks like here, and we'll get it rolling, and you'll explain what we're looking at. And this is, there we go. Okay.
What we're looking at here, Harvey, and we'll talk about this, is the inside of the colon as seen through an instrument that we'll talk about called the colonoscope. The normal appearing bowel goes around 3/4 of the circumference around what you're viewing here. It's pink, it's glistening. And in the base, at just about the 6 o'clock position, there is a lumpy, bumpy area, which in real life is perhaps 1.5 inches in diameter. That, you'll notice, is flat. That is an example of a so-called sessile polyp. If polyps are left alone in certain individuals, those polyps will undergo a transformation, and that's what gives rise to colon cancer. Colon cancer does not come from the clear blue sky. It develops in about 95% of the cases from polyps.
Are we finished with this?
Yes.
Okay, thank you. We're done with that. Okay, so now people have to understand that colon cancer is going to come from something that's growing inside, that it starts out uncancerous, but it becomes precancerous and then cancerous.
Correct.
Okay, so that's why it's important, correct me if I'm wrong, you're the expert, that's why it's important for someone to look at it periodically to make sure you're not having one of those polyps form.
Absolutely. The interesting thing about polyps is that the vast majority of time they are totally asymptomatic, meaning you or I would not know that we're harboring polyps.
Sneaky.
1 in 5 of us harbors polyps over the age of 50. And if you look at when the incidence of colon cancer starts to rise, it also starts to rise after the age of 50. The point being that anyone over the age of 50 is recommended to have a very, very simple screening test, which is very accurate, called a colonoscopy.
It is a simple test.
Absolutely. It's generally done under sedation.
So you don't know what's going on.
Right. It's very, very, very safe. You're sleeping, but you're breathing on your own. It's done by a trained clinical physician. in a specialized suite called a colonoscopy suite. And in essence, what we're doing is using a flexible fiber optic instrument about the size of my index finger, and it is routed retrograde or backwards through that 4 to 5 foot in length rectum and colon that we described earlier, to very carefully look at the lining of the inside of the intestinal tract. These instruments have such great visual acuity that they tremendously aid us in looking and identifying these things called polyps that we described. Now, if we stumble upon a polyp through the course of this procedure,
what do you do?
We have instrumentation that allows us to remove the polyps.
Right then and there?
Absolutely.
Okay.
If they are amenable in terms of their shape and size. If they are too large or the shape is not favorable, regretfully, we have to use another means of getting rid of them.
Right.
But the point is this. The analogy that I like to use is the following. Polyps are benign generally. We always remove them and we biopsy them to ensure that. If you're colonoscoped and polyps are removed, since they are the precursors of cancer, should you remove them, it's analogous to pulling dandelions out of your lawn in the spring if they go to seed. If you do that before they go to seed, your lawn's not going to get overrun with dandelions. By the same token, if you're periodically colonoscoped and we remove polyps, you're never going to get a colon cancer. You're never going to succumb to the second most common cause of cancer, which kills us in the United States.
Now, you mentioned earlier, there are different sizes. I'm going to use layman's terms right now. So there's raised on a stalk, and then there's flat.
Correct.
If you have, and now recently we've seen in Japan that they've been doing studies to show that these super duper flat ones have just been hidden, and that people at times, unless you're really trained in this, people kind of, physicians doing colonoscopies might miss them.
Correct.
Okay? When you find that, how do you biopsy that? Because now it looks like it's flat, it's within the wall. Do you do a brush biopsy to scratch it off? Or do you actually take a piece of it out? Or do you excise the whole thing?
That's a great question. We actually, at times, employ all of the different techniques that you just described. Sometimes, if the flat polyp is too large, we'll just take a representative piece to see if it's benign or malignant. In certain circumstances, with specialty training, we can actually inject a saline solution under the flat polyp and raise it up. And then one of the instruments that we have is a snare. It's almost like a lasso. And we can put it around this, which we've raised up, close the snare down. We use electrocautery so you don't have any bleeding, and then you take the polyp out in that format.
Again, 1 second, I just want to speak to my viewer at home. Please understand something. You don't feel anything. As a matter of fact, you wouldn't even know it's being done. It's just so simple. There's no reason not to get a colonoscope. Okay, let's go back. All right. Okay, so now we're explaining how you can take pieces out, we can see what's going on, so you can catch things at the beginning.
Correct.
When you catch something at the beginning, you have a small lesion that begins, and you see it's an adenoma, it's an adenoma, carcinoma, or a villous adenoma, and you see it at the beginning.
Okay.
Are the chances poor when you get these things very early stage of success in trying to prevent this thing, or it's somebody listening right now watching would say, well, what does it matter anyway once I've got this thing? Explain.
If a polyp is benign, there's no cancer risk to you at that point.
Okay.
So you're kind of solving the problem before it becomes one.
Okay.
That is the whole rationale behind screening colonoscopy. However, in certain unfortunate individuals that either don't get colonoscopies or a number of years have passed between their colonoscopies, or if they ignore some certain simple signs and symptoms which we can speak about, those people may already have a colon cancer at the time of colonoscopy.
Talk about you opened up the next question, your signs and symptoms.
Well, interestingly, colon cancer is often deemed a silent killer. You may have absolutely no signs or symptoms. Should you develop signs or symptoms, what are they? This is certainly not a pleasant topic to discuss.
You got to have it.
But you really need to be in touch with what is quote-unquote normal for your body in terms of bowel function.
Right.
Generally, we all work in clockwork, where every day to 2 days, at a certain time of the day,
Evacuate.
You evacuate. And then generally it is important to gander at what has just come out of you. You want to look at the shape. You want to look at the size. And most importantly, you want to look for blood. Because All too often, we ascribe blood to hemorrhoids. And if it doesn't hurt, we say, can't be colon cancer.
Hemorrhoids.
The point is, cancer of the colon and the rectum generally is painless. So any type of bleeding should raise a red flag. Also, as I said, most of us are rather regular with the way our body functions.
Right.
If at a certain point you're straining more to evacuate,
right,
or the pattern that you've become used to for 40, 50 years has changed, where instead of going once every 2 days, once every day, you're going 4 or 5 times in a day, that's significant. You need to report that to your physician. Or should the diameter of the stool suddenly become pencil thin, that can be a harbinger of a problem.
That means there's an obstruction of some kind?
It means that the colon, which I said is cylindrical or round, is narrowing, so that the waste is kind of getting squeezed through it like you would squeeze toothpaste out of a toothpaste dispenser.
Right.
So a change in one's bowel habits is kind of important. It's very important to report on and note and speak to your physician.
You know, I'm so glad you're having this kind of a discussion, because it's the kind of things that the only time an individual will have this conversation is when it's too late, and they learn and they go, why didn't anyone ever tell me this?
Exactly.
Well, you're hearing it now. Take notes. This is important stuff. Let's talk about diverticulitis. What is it?
Diverticulitis is actually a very, very common problem in our country. It is an infection which develops based upon the existence of a condition called diverticulosis.
Mm-hmm.
Diverticulosis is outpocketings from the colon.
Mm-hmm.
They generally develop on the part of the colon in the left lower abdomen.
Mm-hmm.
It happens to be shaped like the letter S from the Greek sigma. That's called the sigmoid colon. It's depicted on the diagram here. If this is the person's left side, this is the sigmoid colon. This is where the waste is most solid. This is where the colon is contracting more intensely to push the waste out of you.
Mm-hmm.
If we don't have enough fluid and fiber in the diet over decades, the bowel kind of works overtime. And not only does it generate a pressure gradient to push the waste longitudinally or out of the body, it makes a pressure gradient across the colonic wall and can make a small outpocketing. That's what a diverticulum is. These are very small, a couple of millimeters in size. 60% of our population by age 80 develops diverticulosis.
Wow.
But thankfully, 90% of us are asymptomatic. In the unfortunate 10% of individuals that are symptomatic, what happens, Harvey, is that the diverticular neck, which is smaller than the head, gets blocked with a piece of stool, and behind that,
everything is sitting there.
And an infection can inform.
Wow.
The Latin ending for infection is itis, so diverticulitis is the infected or inflamed aspect of diverticulosis. Now, this sometimes just presents with some left lower abdominal pain, and you see your doctor, they give you some antibiotics. They normally confirm this diagnosis with a CAT scan, a specialized X-ray study, but in some individuals, some very significant complications can occur. Diverticulitis can be so severe that the wall can get thinned and pop, like the pimple on an adolescent's chin.
Pop into the peritoneum?
Into the abdominal cavity. So perforated diverticulitis can be a life-threatening emergency. Or an abscess can form in the abdomen. Multiple bouts can lead to a narrowing of the bowel diameter, which can lead to another obstruction or a blockage. And occasionally the bowel will stick itself to some other organ, resulting in something called a fistula. So, how do you know when you have diverticulosis? It's seen when we do a screening colonoscopy.
Again.
Right. So we just mark that.
Keep coming back to that.
Exactly.
Keep coming back to that. How frequently should one have a colonoscopy? And there must be certain classifications as to when you...
Correct.
Explain that, please.
First of all, if you have no family history, meaning a first-degree blood relative does not have colorectal cancer.
Mother, father, sister, brother.
Exactly. The index or first colonoscopy should be done at age 50. If you have a positive family history, meaning mom, dad, brother, or sister has had a colorectal cancer, you should start your screening about 10 years earlier at age 40. Now, these are all for asymptomatic individuals. If at any time you develop rectal bleeding, you need to see the physician. Doesn't matter what your age is. If the first colonoscopy reveals no polyps, it's called negative. Generally, you don't need another one for 5 to 10 years. If you're colonoscoped and a polyp is found, as long as it's benign, you should then have a repeat colonoscopy in about 3 years. So the time that you start And the interval between colonoscopies is contingent upon your family history and what was found at the first colonoscopy. Some other risk factors include having some other benign conditions of the intestinal tract that increase your potential risk of developing colon and rectal cancer. And those include such entities as something called ulcerative colitis or something very common on Long Island called Crohn's disease.
That was my next question. Discuss Crohn's disease because you hear about this a lot. And why is it common on Long Island?
That's very, very interesting. You could go to different parts of the United States and Crohn's disease would be an absolute oddity. It happens to be rampant on Long Island. There's tens of thousands of patients that have quote-unquote inflammatory bowel disease, which comprises both Crohn's disease and ulcerative colitis. We can kind of compare and contrast them. Crohn's disease is an inflammatory condition that can affect any part of the intestinal tract that we previously described. It can even manifest with ulcerations in one's mouth, which we call aphthous ulcers. However, the most commonly afflicted part of the GI tract is the end of the small bowel, where the small bowel is attaching to the colon. We call that the terminal ileum. This disease leads to swelling of the intestine, and the swelling can make that tube-like center of the intestinal tract narrow. If it narrows, the analogy again that I use is that it's like having the main drain in your house, get some roots in it, and the kids flush down a lot of toilet paper, everything's going to get stuck and it's going to back up. One of the most common presenting symptoms of Crohn's disease is obstructive symptoms. Bad cramping, sometimes the abdomen gets distended, can even lead to nausea, vomiting. To continue with Crohn's, though it most frequently afflicts the small intestine, it can affect the colon and the rectum. Spots can be normal and parts can be abnormal. It's a segmentally, it's noted to be segmentally affecting the GI tract.
What does one see in a colonoscopy to know? Well, first, can you use a colonoscopy to see any changes? Is this something that is noted histologically by taking a sample and see it on the slides? How does one diagnose it, other than symptoms?
Well, here's what happens. Here's what happens. Generally, the symptoms will be
classic cardinal?
Well, no, they'll be attributed to a quote queasy stomach,
Okay.
or it can be glossed over for months to years. But sometimes, due to persistence of the symptoms, or weight loss, or just generalized malaise, not feeling well, you'll see your internist. The internist is generally perceptive enough to get you in the hands of a specialist called a gastroenterologist, a medical doctor with a specialty in diagnosing and treating problems of the GI tract. Then you need to have a consortium of tests to be done, including some x-rays, sometimes an upper GI series where you would drink some white barium material, and they take pictures of the upper intestinal tract and the small intestine, and then we normally link that with the performance of either a sigmoidoscopy, where we look partway into the colon, or a colonoscopy, where we look into the entire colon. Now, there are certain changes that can be seen with the experienced eye that tell us, hey, this is Crohn's disease. But remember, colonoscopy can be normal, and the Crohn's can actually affect the small intestine. When you look at both the upper GI series and the colonoscopy, it helps make the diagnosis.
I see. When you do a colonoscopy, someone says, okay, get me one of those. I'm in the mood for one. When you do a colonoscopy, how far up do you go? Do you go from you go from the large bowel, the small bowel, and all that? I mean,
a colonoscopy, first of all, I must say that a colonoscopy is only effective if the patient takes a PrEP. Well, it makes sense that
we didn't even discuss that. Briefly.
Very importantly, the day before a colonoscopy, you take only clear liquids. You also, that afternoon or evening before the scheduled procedure, must drink something called a cathartic, a substance going to clear out your intestinal tract.
But good.
Right, because it needs to be free of the waste matter so that we can use our flexible instrument to actually see what's going on. Anyway, a colonoscopy looks from the anus retrograde or backwards through the 4 to 5 foot length of the rectum, the colon, and sometimes we can just peek into the end of the small intestine. You cannot use a colonoscope to look into the small intestine.
Why not? The valve is too...
The scope's not long enough.
Okay.
That's the main issue. The scope is 160 centimeters in length.
Okay.
That's about 3 to 4 feet. That does not get you into the 20 feet of small intestine. Interestingly, there have been some new technologies that have developed to study the small intestinal tract. And one of them is called capsule endoscopy.
Oh, yeah.
Where we really can't use a 20-foot scope to look in the intestine. It's an impossibility. So amazingly, what they've been able to do is develop a little camera, a capsule which can be swallowed, and it takes images of the entire small intestine, which then can be downloaded onto a computer, and it's a means of looking for pathology in the small intestine. It's absolutely amazing.
And is this something that you use, I'm not saying on a daily basis, but it's something that you have access to if somebody comes in and needs it?
Generally, gastroenterologists. I'm a colorectal surgeon.
Oh, okay, so a gastroenterologist
exactly.
would be using that.
For instance, if people have hidden bleeding or anemia, blood loss seems to be coming from the GI tract, colonoscopy is normal. Upper endoscopy is normal. Small bowel series seems to be normal, but we need a more accurate look at the small intestine. That's where capsule endoscopy would come in.
So this capsule endoscopy is the most accurate way to visualize things today. Is that correct?
Of the small intestine.
Of the small intestine.
The gold standard for looking for pathology in the large intestine is colonoscopy.
I see. Okay. This is good. Okay, so we went over the signs and symptoms of colon cancer.
Correct.
About bleeding usually. And
change in bowel habits.
Change in bowel habits. Did we discuss risk? I mean, what can somebody do? We only got about 3 minutes left. What can somebody? There's so many other things. You're going to have to come back sometime. What are the risk factors besides genetics?
Well, that actually happens to be a main risk factor.
Right.
A main risk factor.
What is it? Diet?
Family history is very significant. The incidence of anyone getting a colorectal cancer in the United States is 1 in 17 with a negative family history. If a blood relative has this disease, it increases your potential risk 3 to 10-fold.
Wow.
So genetics are important. Only 5% of all colorectal cancers have actually been linked directly to a genetic problem, but it is supposed that there is some problem with the system, the immune system, which normally monitors bad colonic cells and sweeps them out. In the individuals who develop colorectal cancer, that cleansing area, that ability to detect the abnormal cell seems to go awry. So genetics, some element of a risk factor. It has been looked at in terms of countries. The United States has a much higher incidence of colorectal cancer than other countries where there's a diet which is very high in fiber. So high fiber.
That was the next thing I wanted to ask you.
Is protective.
We've got a minute left. So it's important for people to make sure that they get good fiber, whether it's in the form of a supplement or eating well.
Fruits, vegetables, salads.
Fruits, vegetables, or there's so many things on the market today that one can use. I don't want to mention names right now, products, but they can just mix it up in some water and just take it.
Exactly. And
take it once, twice, or 3 times a day, depending upon their need, and go see your doctor. So let your doctor tell you what you should be doing. And that really would help a lot, I would imagine. Listen, there's so many more things I wanted to ask you, but we're out of time. Do you believe how fast the time goes?
No.
Incredible. It just flies.
If I could say one thing.
Go ahead, before you get the hook.
The key thing is don't be afraid to get tested. It can save your life. It's a painless procedure which can save your life.
It's amazing. People then say, oh, why didn't I think of it? And then the family's crying because you're dying. And it's terrible. It's terrible. Unbelievable. Dr. John Procaccino, Director of Colorectal Surgery at North Shore LIJ. Thanks very much for taking the time to come down. I got you on TV answering this question. You going to come down again for some more stuff?
I'd love to.
Okay, I got you. I heard you got you saying it.
Thank you. Thanks for having me.
My pleasure. I hope you enjoyed. This was a great, great time for all of us to learn. Get yourself a colonoscopy. He's running a sale. I'm only kidding. Get yourself a colonoscopy. Very important. The life you may save may be yours, and you'll be around longer for your family. It's preventable when you get these things done early. Okay, Dr. Pass is saying, whatever you do, just like Dr. John Procaccino, do it with passion. Care about it. Otherwise, why do it at all? See you again next time.